Good day, everyone, and welcome to our webinar on the mental health repercussions of the COVID-19 crisis in Belgium. My name is Brecht de Vleeschouwer. I'm head of the service Lifestyle and Chronic Diseases at Sciensano, the Belgian Institute for Health, and I will be your host for today. So in this webinar, we will explore how mental health has been impacted and has evolved throughout the COVID-19 crisis. And to explore this topic, we have invited three leading researchers in the field of mental health to share their findings on mental health during the COVID-19 crisis. Later on, we will present the program and we will introduce the different speakers one by one. First, I want to mention that this webinar is organized in the context of the HELICON project, which is supported by BELSPO and coordinated by our team. And the aim of the HELICON project is to unravel social inequalities and long-term and indirect health effects of the COVID-19 crisis in Belgium. So while Sciensano has mainly been known for its data, its numbers on the acute impact of the crisis, number of cases, hospitalizations and deaths, vaccination as well, we also want to understand the more distal effects of the crisis. So the aim of this project is to generate, collect, but also disseminate evidence across three main pillars: social inequalities in the COVID-19 burden, the effects of long COVID, post-COVID conditions, and the focus of today's webinar, the indirect public health effects of the crisis, with on the one hand the effects of delayed healthcare use, but on the other hand, of course, also a big impact on our mental health. And this will be the focus of today's webinar. As mentioned, we've invited different key experts in the domain who have been actively involved in monitoring mental health throughout the crisis. First, we will have Dr. Nele Flamant, who will present the activities that Sciensano conducted throughout the pandemic. Then we will have Professor Maarten van Steenkiste from Ghent University, who will present the key insights from the Motivation Barometer project that they coordinate. And finally, we will have Professor Elke van Hoof from the Free University of Brussels, who will give her insights on the impact of COVID on mental health, also based on the work that she coordinated within the Superior Health Council. After every presentation, there will be time for some questions from the audience. And at the end of the webinar, we will have concluding remarks from Ms. Isabel Moens, who's an advisor to the Federal Minister of Health, Van den Broeke, and is an expert as well in mental health policy. Before we get started, some very practical questions. We ask each of you to keep your microphones switched off during the presentations to avoid any unpleasant background noises. You can, of course, keep your video on so that we know who we are talking to. If you have questions during the presentations or afterwards, feel free to put them in the chat or the Q&A. And there's also an option to raise your hand if you want to take the floor. So with this introduction, I would like to start by introducing our first speaker. And our first speaker will be Nele Flamant, who obtained a PhD in psychology at Ghent University. She's currently working as a scientist at Sciensano, where she is co-organizing the Bell Health project, which aims to set up a longitudinal cohort to examine the impact of multiple stress sources on mental health. In this webinar, she will present the results of the different health interview surveys that Sciensano conducted before and during the pandemic, and the lessons that we can learn from these surveys. So with that, I want to thank all of you for being present here today, and I'm very happy now to give the floor to Nele. Thank you.
Thank you, Brecht. I'll share my screen. Okay, so I hope you can all see my screen. So that's
perfect.
Okay, perfect. So good afternoon, everyone. So in my presentation today towards mental health in Belgium, survey results before and during the pandemic, I will present you the main results of the COVID-19 health surveys. Now, first, I'll go over the purpose and the methodology of the COVID health surveys. In the second section, I'll show you the main results and we'll compare mental health during the pandemic to mental health before the pandemic. And finally, I'll discuss some implications and suggestions for the future. So the COVID-19 health surveys were organized from April 2020 to June 2022. And the main goal was to monitor and examine the impact of the COVID-19 pandemic on the health and health behavior of the Belgian adult population. And to this aim, the COVID-19 health surveys were organized online 11 times, with the first time being in the beginning of April, exactly 2 weeks after the start of the first lockdown in Belgium. Now, the survey was announced through several channels. It was published on the Sciensano website, and an invitation email was sent to Sciensano employees with the request to forward the invitation to friends and family. It was also mentioned in the press and distributed via social media. And starting from wave 2, participants from previous waves received an invitation email with the invitation to again participate in the current wave. And finally, in some waves, invitations were sent to specific organizations. For example, because the younger age groups were underrepresented, emails were sent to sport clubs and they forwarded the invitation to their members. Now, in total, we had almost 300,000 data points over 11 waves. Unfortunately, because not all participants agreed to have their data linked over time, we do not know exactly how many unique individuals participated. But as you can see in the graph, the number of participants was very high in the start of the pandemic and then decreased linearly to March 2021, from where on we had a quite stable number of participants with on average 20,000 individuals per wave. Now, because our sample was a convenience sample, it was not a good representation of the total population in Belgium. And similar to other COVID-19 studies, our participants were mostly female, higher educated, and we had an underrepresentation of individuals between 18 and 24 years old. So therefore, the results I will show you today were weighted results for gender, age, educational level, and region. So in the next section, we'll discuss the impact of the pandemic on mental health in Belgium. Now, depression and anxiety were measured 10 times, which really gave us the opportunity to see the evolution in anxiety and depression over time. And here you can see the evolution of anxiety, which is represented by the red line, and depression, which is represented by the green line. Now, the dotted lines are the levels of anxiety and depression in Belgium in 2018, as measured by the Health Interview Survey, which used the same instruments as the COVID-19 health surveys. And as you can see, there was a substantial increase in reporting anxiety and depression problems during the crisis compared to pre-pandemic levels. Now, the prevalence of anxiety and depression in Belgium was very high, and similar results were also found in neighboring countries. And as you can see, the evolution in mental health problems is closely related to the rise in COVID-19 contamination, as well as to the strictness of the measures. And it's interesting to see that even at times when there was little COVID contamination and no measures, levels of anxiety and depression never returned to pre-pandemic levels. Now, the groups who were most vulnerable to mental health problems were women, people living alone, people with a lower educational level, and younger people. We also systematically in each wave examined the degree to which people were dissatisfied with their social contacts. And here in the graph, you can see the percentage of people who indicated to be really or rather unsatisfied with their social contacts in the past 2 weeks. And as you can see, this percentage has increased a lot during the pandemic. Before the pandemic, so in 2018, using the same instrument, only 9% of the people reported to be dissatisfied. But this number increased to more than 60% during the pandemic. We also see substantial differences between the different time moments. And as you can see, the percentage of people who are dissatisfied is especially high in times of strict measures and lockdown periods. And although the numbers have decreased to 20% in March and June this year, it is worrying that in March 2022, 20% of the people still reported to feel severely lonely. Overall, older people were more satisfied with their social contacts than young. Now, finally, I also want to show you some results regarding suicidal thoughts. And in March 2022, we asked about the prevalence of suicidal thoughts. Now, 80% of the people reported to never had such thoughts before. 9% reported to have had such thoughts, but only before the pandemic. 8.5% reported to have had such thoughts both before and during the pandemic. And 2.5% reported to have had such thoughts only during the pandemic. To the people who reported to have had such thoughts both before and during the pandemic, a follow-up question was asked regarding the frequency of these thoughts. And specifically, we asked whether these thoughts had increased since the start of the pandemic, whether they had decreased, or whether the frequency remained the same. And here you can see that most people reported that the frequency of those thoughts did not change. 18% reported that the frequency of these thoughts had decreased since the start of the pandemic, but for a large group, 39% reported that the frequency of these thoughts had increased since the start of the pandemic. Of course, we have to be careful when interpreting this, as a recency bias may be of effect here. Now, we also asked about suicide behavior, and fortunately, we found no evidence that this had increased since the pandemic. Now, overall, the risk groups for mental health problems during the pandemic were younger people, women, people living alone or alone with children, people with lower educational levels, people who were unintentionally out of work, and people with incapacities or prior psychological fragility. Now, of course, these are the risk groups that are more vulnerable to mental health problems in general and not only specific during the COVID-19 pandemic. Now, I want to end this presentation with some implications and suggestions for the future. As you can see here, this is a figure from the World Happiness Reports, and it shows 4 key phases that outline the impact of the pandemic on mental health. And as you can see, there are 2 more short-term phases, which are the immediate fear of the virus and worries about lockdown measures. And second, to the broader adversities, both economic and social, created by the pandemic and the government's response to it. Now, the data of the COVID-19 health surveys focused on these 2 phases. But there will also be longer-term effects of the pandemic due to its subsequent effect on the demand for and the supply of mental health services, as well as the even longer-term mental health consequences of recession, unrest, and poverty. Now, these latter stages may also be substantial, and therefore we believe it's important to continue monitoring mental health also after the pandemic and examine factors that could make us more resilient. Now, I want to show you some data on such resilience, and here you see the evolution of anxiety over time for 3 groups of people. The orange line represents people who say they have a hard time making it through stressful events, so people who report low resilience. And as you can see, their level of anxiety is significantly higher during the pandemic compared to people who report high levels of resilience, as represented by the blue line, or people who report average levels of resilience, as represented by the green line. So it's important to examine which factors may protect us during times of stress and crisis, such as social support, coping skills, and emotion regulation. So we can conclude that the COVID-19 pandemic did not only affect physical health, but has also severely impacted mental health and well-being. And even when the pandemic is over, it remains important to keep monitoring the long-term effects of the pandemic on mental health. In addition, it's important to examine changeable factors that could protect us in times of crisis and which can be targeted in interventions and preventions. Now, to these aims, Sciensano is launching the Bell Health cohort, for which the first wave is now in September. And I want to show you one final slide about this Bell Health cohort, or in long, the Belgian Health and Wellbeing cohort, which is a longitudinal epidemiological study for at least 2 years in the general population living in Belgium. And the sample partially consists of participants of the COVID-19 health surveys, which gives us the opportunity to really examine causal effects over time. Now, the Bell Health cohort has 3 main aims. First, to monitor the evolution of health and well-being in Belgium in the aftermath of the COVID-19 pandemic. The second aim is to identify the impact of major global threatening events, such as the energy crisis and the climate crisis, on the health and well-being of the Belgian population. And the final aim is to identify changeable factors that can increase resilience in times of uncertainty and distress. So I want to thank you for your time and attention, and I don't know if there are any remaining questions, otherwise I'm happy to answer.
Yeah, perfect. Thanks a lot, Nele, for this very interesting presentation. We do have time for some questions, so if you would have any burning questions for Nele, feel free to put them in the chat or raise your hand to take the floor directly. In any case, it's interesting to see that the activities that were set up during the COVID crisis will evolve and will continue in a way that is not longer linked to COVID per se, but that will tackle all the challenges that we are facing today. So that's indeed a very important evolution. You also refer to resilience quite a lot, and this is indeed a topic, a concept that is now gaining a lot of attention. But can you maybe explain how you interpret this concept of resilience and answering the questions that you have raised yourself, how we could as a society increase our resilience? Thank you.
Yeah, for me, resilience is more of a general term, like more an umbrella term for me. And I think a lot of different factors can fall under resilience. And a part of this will be factors that we don't really have an impact on, like personality, genetics. But I think as researchers, it's very important to focus on the factors that we can change and that we can have an impact on, such as, for example, how we cope with such feelings of stress and such crisis. Also, the social support we get, or emotion regulation, for example, indeed, like I mentioned. So I think it's very important to first examine how these multiple factors can maybe indeed buffer the effects of the COVID-19 pandemic on our depression and anxiety. And in a second step, of course, how we can influence this in the population. So how can we increase adaptive emotion regulation? How can we learn people to cope with such threatening events in an adaptive way? So I think that's important for the future, definitely.
Yeah. Okay, perfect. Thanks a lot. So then I suggest we move on to our next speaker. So thanks once again, Nele, for the very good presentation. Our second speaker is Professor Maarten van Steenkiste, who is a professor in developmental and motivational psychology at Ghent University. During the crisis, he was a member of the Management Strategy Expert Group, the GEMS, and one of his research projects that he initiated during the crisis was the Motivation Barometer, which aimed to improve our understanding of the psychological impact of the coronacrisis. And his presentation will provide a helicopter perspective of the key findings and lessons learned from this large-scale study. So I see you have your presentation up. Thanks a lot, Maarten, and feel free to take the floor. Thank you.
Thank you, Brecht. Hello, everybody. I'm happy to indeed share here a number of insights from the Motivation Barometer project, which was a broad inter-university project where different scholars were involved. And not just people or scholars from Flanders, because at the University of Ghent, some of us were involved with it, but also people from Leuven and from the French-speaking part in Belgium. So I think overall, this was a pretty, let's say, unusual or exceptional collaboration, which is still going on today because we try to indeed also get the work published in the academic community to, let's say, also get input there. But overall, I want to say something more about the methodology of the Motivation Barometer and maybe also highlight a little bit the differences with the way with what Sciensano has been doing, what indeed Nele did. I think it's interesting to see the complementarities and the differences there. I think we try to take a picture, so to speak, and to use a metaphor, the Motivation Barometer is a systematic monitoring instrument to assess the psychological temperature of the population on critical moments during the pandemic. And we try to assess a variety of different aspects of people's functioning, affective indicators, cognitive, motivational, behavioral. I will focus mainly today on more the well-being related results, but of course we have been doing a lot of work also on the motivational impact as such. And if I can say something more specifically about the method, I think our method was a very dynamic one in the sense that we didn't plan to launch waves on predetermined moments. So not, let's say, every 2 months or every 2 weeks. No, given the varying circumstances of the pandemic, we actually launched new waves as new urgencies came up in the pandemic. So it was really flexible in that perspective. Second, I want to highlight here that I think we try to also move beyond what we would call a more symptomatic approach. And symptomatic, I mean with this, that is like, let's say, well-being, indicators of well-being and ill-being are maybe just the surface, because underlying, you need to pay attention to the processes predicting well-being. And we will discuss more the issue of basic psychological needs, which is very fundamental as a precursor of people's well-being. In the case of behavior, the underlying factor there is, of course, motivation. So we focus in a theory-driven manner on the processes predicting those critical outcomes. Third, I think the methodology was fairly broad, both in terms of, let's say, the topics addressed. We had motivation, vaccination, emotion regulation, risk perception, trust, and so on, but also the samples, which were pretty diverse, and also the method itself. On the one hand, we had new waves coming in total 109 waves that were launched across these 2 years. But also we followed up some of these participants longitudinally, used interventions and vignette-based studies. And overall, I think we had here a sample, much as what Nele described before, was not completely representative of the population. More females were present, somewhat older compared to, let's say, the representative age number in the population. Yet it was done across all provinces. And overall, we had 109 waves, 700, almost 800 days of assessments, and 463,000 people who participated. We also controlled for the non-representative nature of the findings by weighting some of these data depending on a number of sociodemographics, like indeed educational level, age, and gender. And so we came out with reports on a regular basis, in total 41. You can find them on the website of the Motivation Barometer, but I want to highlight a few findings here. The first question is, when did the population suffer, so to speak? And I think more specifically, you can ask the question whether strict measures, are they by definition increasing, for instance, the mental problems, or are they reducing mental problems? And I have here the findings with me for anxiety, which is the yellow line. And you see ups and downs across the pandemic here. And I want to highlight here one particular moment, which was October, November in 21, or in 2020, better. On that moment, there was a new government installed, and maybe you recall that moment when indeed there was a second important wave coming up. And in October, they were hesitating to take decisions to move on to a stricter regime. And what you can see here is that anxiety was really going up in society. People were concerned indeed, how is the situation evolving? And on the moment the lockdown was introduced, you see that anxiety is going down. So I want to highlight here that indeed anxiety increases if corona numbers increase as well. But on the other hand, you see you can keep this anxiety more under control when indeed stricter measures are introduced which serve as a buffer against increasing anxiety. So that's one, I think, finding. These are other indicators measuring here life satisfaction and vitality. And what you can see here is maybe there on the left, in summertime, people report better life satisfaction, higher vitality. This is in July 2020. After the first lockdown, recall, we enjoyed more freedom at that moment. And then all by a sudden in Antwerpen, there is in that province in particular, there is a new lockdown introduced. And this decreases substantially. And I think one of the reasons why you see this strong dip here in life satisfaction on that moment is that some of the measures were perceived to be disproportional. So while on the one hand, strict measures can buffer anxiety, the strict measures need to be perceived as proportional to still preserve people's well-being. Another observation here is that you can see that in the winter time of 21, and I think the findings in Sciensano also highlight this was the most difficult period for people overall. You see overall it's lower than on that moment, and on the moment the vaccination campaign starts to roll out, people's vitality and life satisfaction goes again up as we move into the summer of 21. So this is the when question, but for us, I think an important question is also how can we account for the variation in people's well-being and ill-being across time? So are there some systematic important processes underlying the variation in well-being? And here we take very much a psychological perspective grounded in self-determination theory, where we pay attention to people's psychological needs. We all do have physiological needs, like we need to eat sufficiently and drink in order to survive and grow, but also we have a set of psychological needs, which are deemed to be very essential for people's functioning. If you don't have those needs met, people will suffer. And this would hold for people across the world. So it's not just culture bounded. No, those psychological needs are presumed to have a universal impact. And in the literature, 3 different needs have been proposed. That is, one is autonomy, that is the experience of a sense of volition and freedom, while in the case of frustration, you experience pressure and conflict. Second is relatedness, where you experience a sense of connection and care, satisfaction with relationships, as Nele talked about it as well, or a sense of rejection and loneliness when relatedness is frustrated. And then you have competence, whether people feel effective, for instance, effective to deal with the situation, or they feel like a failure and they feel inadequate, doubting their skills to handle the situation. And so I have a question for you. And I want you to, let's say, guess for a minute for yourself, which of those 3 basic psychological needs was most under threat during the pandemic? If you would do a prediction, do you think it's autonomy, it's relatedness, or is it competence? So which of those 3 were most under threat in your mind, according to your opinion? So these are the data, and most people, in fact, would predict that relatedness was the most threatened need, but that's not what the findings suggest. What the findings indicate here is that autonomy was by far the most threatened need of the 3. And you can see that there are ups and downs in these basic psychological needs, and it's not a coincidence that those needs co-vary with the ups and downs in people's well-being and ill-being. So to the extent basic needs get satisfied more, people report better well-being, more vitality, more energy they have available. When the needs get frustrated, especially during, for instance, the wintertime 21, you can see autonomy was consistently under the horizontal line there in the middle, and the horizontal line denotes the flipping point from satisfaction to frustration. So people felt ongoingly, almost chronically frustrated in their basic need for autonomy on that moment, which also explains why well-being was becoming such a hot topic in the wintertime of 21. But apart from those 3 needs, we also looked at security. Security where people would experience a sense of certainty and control, but also a sense of uncertainty or unpredictability regarding the overall situation. And so we assessed different indicators of uncertainty and involving, for instance, uncertainty regarding the overall situation. And you can see this is the green findings there. And this form of uncertainty was across the pandemic more prevalent than other forms of uncertainty, like health-related uncertainty or uncertainty with respect to financial issues. And what you can see again is here in October, on that moment when they were hesitating to introduce stricter measures, you see the uncertainty going up. This is also one of the reasons why we for such a long time argued in favor of the Corona Barometer, because we thought, okay, when the barometer is introduced, at least it provides a sense of predictability to the population, when people know when exactly, or more precisely, when you would shift to, let's say, more stricter or more relaxed measures across time. And then the third and final question concerns who was the person, or who are the groups of people suffering the most. And I highlight here 2 different issues. On the one hand, we noted important vaccination differences here. in basic psychological needs. And you see that the full line represents, in this case, people who were not vaccinated, while the dotted lines are the vaccinated people. And you can see there's a consistent difference between the two. The unvaccinated suffered from less autonomy, and they felt more excluded from other groups. And you can see that the gap between the two groups is widening on the moment the Corona Pass was introduced. So the Corona Pass actually, I think, to some extent led to a further gap discrepancy between the two groups. On the moment the Corona Pass was again removed in March this year, you can see that the differences between the two groups also disappear on that moment. So I think this is an important consideration to take into account when we think about the role of the Corona Pass overall. And then I think another finding here is that there are systematic age differences. Also, Nele highlighted this with younger people suffering more, and you can really see this is due to autonomy, which was the most frustrated need in this case. Younger populations who are adolescents, for instance, used indeed to enjoy more freedom. They are in a period in their lives where they build their identities, build a new social network, and this was all put on hold, of course, which was very hard for them on that moment. And so if I can conclude here, I have, let's say, 4 take-home messages. Well-being is not just a matter of relaxing and constraining measures. It's more complicated. There's a dynamic interplay between the stringency of the measures and the proportionality as a function of the moment when the measures are introduced. And that, of course, also depends on virus circulation in the moment, on that moment. So it's these different factors who are at play in a given moment. Second, I think in future well-being assessments, we should move beyond the symptomatic approach and systematically include basic psychological needs as key drivers underlying both variation in well-being and ill-being. And if you assess those basic needs, you can maybe intervene earlier on. So it's from a preventive standpoint very critical to assess those needs earlier on. Third, well-being is not just about maximizing positive affect, and I would add minimizing negative affect. It's about developing awareness and inner interest for a wide variety of negative emotions. So I think many of us were suffering during the Corona crisis. We were all facing a wide variety of emotions. We were sometimes indeed maybe irritated. We were sad. We were hopeful. I think it's about developing inner interest, and that's all about sustaining or facilitating integrative emotion regulation in the population. And finally, I think if we talk about resilience from a more preventive perspective, of course, this is very critical that we come up with validated and universal e-health interventions that are also made accessible to the broader population. And during the Corona crisis, we actually developed an intervention which actually zoomed in on those basic psychological needs. So people in this case are encouraged to participate in an e-health intervention where on a daily basis during 7 days, they try to maximize their basic psychological needs. We found this intervention to be successful in the broader population, and we have made it also available in that respect so others could benefit from it. But this is just an example, I think, of what concretely resilience may mean. It means trying to invest in your own basic psychological needs in order to optimize your own mental health. Thank you for your attention.
Yeah, wonderful. Thanks a lot, Maarten. Indeed, very interesting to see that with different methodologies, you arrive at similar conclusions as with the previous speaker, but that you also are able to obtain insights that are more detailed, more sensitive. So it's very good to see the complementary between the different approaches, and also appreciated a lot the grounding of your insights in psychological theory. I think that's a very important added value of the work that you are doing, of course. Good. So we have again time for some questions. So feel free to use the chat or raise your hand. And I see, yeah, Anouk, that you have a question. Feel free to take the floor, Anouk.
Thank you. I didn't know that I can write it down in the chat. Thank you for this very interesting presentation. I was wondering if you mentioned a lot the measure and at that time it was this kind of measure, but you don't take into account the incidence, the prevalence, the mortality at that time. And so maybe there is a link with the fact that the people were feeling impuissant. Is not the most problem is not that they have no contact, but that they feel incompetent. Maybe it's this linked with the number of cases, the number of mortality at that time. Well, I will be glad to hear you about this. The anxiety may be linked to that before to the measure. That was my reflection, and it will mean that it will have other conclusion for the action we have to take to help people if it is being able to act on his health and the public health, or act on the social link. Not sure if I'm clear. Thank you.
Thank you. I think both, let's say, virus circulation and the type of measures that are put in place at a given moment in time play a role in predicting people's well-being on that moment. So to the extent the virus circulation is going up and the hospitals get filled, well, you see indeed that people's uncertainties about getting infected themselves and the uncertainty about the overall situation is going up. So this has a cost in terms of increasing anxiety. So that's, I think, clear there that virus circulation, if it's not kept under control with stringent measures, this may have a cost. On the other hand, if the measures at some point are perceived to be illegitimate, meaning that they are disproportional compared to, let's say, how much virus circulation, how much threat you still have in society, then people start to question the measures and they experience them more as autonomy frustrating. Because they say, okay, this is no longer legitimate, and so why should I still stick to them? They feel as a burden to me. And so that's, of course, all depends on, let's say, what are the fitting measures on a given moment in light of, okay, virus circulation at that moment, and the perception of the population regarding indeed the effectiveness of the measures also. So I'm not sure whether that responds a bit to your question.
Mm-hmm. Yeah, perfect. And I see a very nice follow-up question in the chat by Gunther Mattheussens. How do you explain that anxiety and depressions are still higher now than before the pandemic, even though there are no more measures, or at least not the same amount of measures as we used to know?
Well, I would think there are, of course, other, let's say, worries that have come up now. We also, in the last waves of the Motivation Barometer, we have been assessing, for instance, people's worries regarding the war, the worries regarding climate change. So I think, yeah, to some extent, also what Nele alluded upon, let's say, earlier worries were maybe replaced by new ones. And maybe the question is this really accounting for the higher prevalence? I'm not sure, but I think, well, the advantage of these long-term projects is now that we can continue them in the future and we have a comparison reference point to see how things are evolving.
Yeah, indeed. And again, a strong call to continue with these projects, these monitoring systems, even though COVID is maybe no longer a priority, but there are still many other concerning elements in society that will continue affecting mental health. Thanks. With that, I would like to thank you, Maarten, once again for the very insightful presentation, and then would like to move on to our third speaker, Professor Elke van Hoof, who is teaching medical and health psychology as well as clinical psychological interventions at the Vrije Universiteit Brussels. She is also the chairperson of the Superior Health Council Working Group on the psychological impact on COVID-19, and from this experience she will present us her insights on the impact of COVID on mental health. So Elke, feel free to take the floor. Thank you.
Thank you, Brecht, for the introduction, and thank you all for being here. Let me just start by discussing first mental health, the importance of mental health, which we should not forget, because I think that's also one of the reasons that I took the role as chair within the Superior Health Council. Mental health is a basic human right, and I think that was kind of like the the light, the Northern Star that we took within our work. It's not just a basic human right, but we know for years now that it is crucial to personal, community, and socio-economic development. And for that, it is very important to have very good numbers and a very good structure to monitor mental health, screen target groups, and to indeed, as Maarten already suggested, have very good and efficient interventions at hand. Now, just by setting the scene once more is, of course, before the pandemic, we were already underfinanced. As I'm just sharing some slides from a very interesting report that we also published in one of the recent advices of the Superior Health Council. For those who want to look it up, it's 9665, the number of the advice, where we actually indicated how deeply we are struggling with underfinancing in mental health research, of course, leading us astray in disruptions like the pandemic. Why leading us astray? Because the thing that I've heard most was show us some hardcore figures, not just experiences from the people in the field or from the people, the public. Give us some hardcore figures, but if you are underfinancing such a tremendously important domain, we cannot present you hardcore figures, and not even in a crisis. Although we have seen some very interesting things that have been set up within Sciensano. Also a good example was the Motivation Barometer and the research that was done at the French-speaking part with the youngsters, also a very good example. So I think we as Belgium did quite a good job. Now, going back to the beginning of the pandemic in March 2020, we were asked, or I was asked within the Superior Health Council to take on the lead, because we wanted to know what we could expect from the pandemic. So we had like 3 questions to answer. Can you provide us with the already existing science so we can create a framework? And what do we already know that we can expect in how the public will respond to this? And these 3 questions needed to provide a context in which the evolutions could be interpreted, because everybody expected that this was going to be very hard. In a way, we wanted a lighthouse to use within the expected chaos. So we could provide people with a perceived sense of control as we could offer them a narrative. That was actually the question posed to myself as the chair within the Superior Health Council from March 2020 on. Of course, there was not so much at hand, so we started with what was already known. And this is kind of like a structure on how we actually moved forward. We first went and looked into the already existing literature. Was there somewhere in the past something similar that elicited the same emotions or with the same impact in society? If yes, what did we learn from that? From that, we published a scoping review, also giving a model, a narrative to policymakers to help the public to support them with the perceived control. I will go into detail in a minute. Now, if yes, if we have such experiences, what did we do back then to solve it? And is that something we can use here? And for that, we used expert groups, more than 3,500 people, experts from the field, people, academics, but also psychologists, psychiatrists, sociologists, people who were dealing with everybody of the public. And then we created the Belgian mental health data repository, which became actually a paper repository because scientists were not so willing to share data in the end after all. And then the final question was, if we know all that, what do we need to turn it into a success so we can manage better mental health challenges in Belgium? So that was actually what we did from March 2020 on. And this is exactly the number of experts, people in the field that were implicated in this work. And also for you, just to know, if you want to go in depth, there's a lot of things that are published today that is at your convenience. Also interesting that I want to highlight the narrative to support people in keeping their perceived control was published in May 2020. And you've heard from Maarten how important that is, that people really are able to keep that sense of autonomy, that sense of control. So that was the first thing we wanted to answer. Unfortunately, it was never used by the policymakers. And I think that is a missed opportunity. Based on all the work, we also provided some recommendations, and recommendations I want to share with you rather than some facts and figures and numbers, because I think you've heard already some intriguing numbers and the numbers of best quality. Also, the other ones you can look into in the Belgian Health paper repository. But based on all that, we actually created 10 recommendations for within the pandemic, but also afterwards, what we deem necessary. The first one is, of course, directly linked to the pandemic, which is now not over, in such a way also presented already by the first speaker, that we are in a post-pandemic, and that's also something that needs to be managed. Literature actually reveals up to 2 years after the time where we say this can be over. And I think we have not reached that point yet. But also that we need, whatever we do, to reinforce natural adaptation processes, because people are in the end very resilient. We adapt, but we adapt when we are able to use our basic psychological processes. And we should do that by activating already existing resources. One of the first advices was to try to create a magazine or a program on the television to teach people the narrative and to teach them what they could do. Unfortunately, that's also something that wasn't taken on by policymakers. We also said monitor psychosocial impact, and I'm very fortunate to see that a lot of those initiatives in the end were taken on across Belgium, but also far beyond now, so we can really bridge that gap now. Treat psychological dysfunctioning as soon as possible, but also there we have still up until now a pitfall where we are lacking good triage guidelines. What is it, psychosocial dysfunctioning? Because it's not because you have an increased anxiety or an increased depression level that we should look at it as dysfunctional. And therefore, we actually lack good guidelines, good definitions, and also systems that allow us to target people who are dysfunctioning and refer them to the best possible support necessary. So there, even now, we have a gap that is not being closed as we speak. High quality treatment is of course necessary, and then the dispatching, the referral system that I was just talking about was also actually put forward early in the beginning of the pandemic. But also something very important, we identified groups at risk based on the already existing literature to help target persons and to make sure that the scarce resources that we expected to have could be actually sent to the people who need them the most. By using familiar pathways, but also to go and look at those, to search those groups at risk. Also, something that we said is do not minimize the impact of the quarantine, lockdown, or fear of COVID-19. I think that is also a missed opportunity in the previous government. And breach social isolation, because indeed in the already existing literature, the social isolation and the importance of social cohesion was already put forward for many decades as one of the major predictors of mental distress during such events. Now, based on this, we also created the narrative, and this is the narrative that we actually designed. It's currently already published, as you can see, and what we've created was based on what we call the phase of response to disaster model, which is as old as in the 80s of the last century. And we actually adapted it so we could use it during the pandemic. As you can see here, what is very important, and for that, the importance of targeting groups at risk, is we need to be aware that at the beginning of the pandemic, some of us started with a battery, a good mental health or a good physical health, and others already had some challenges before the pandemic. And of course, that differentiation also impacts the way you respond to a disruption. People, and that appears very logic, people who already appear at the start with some challenges will have a major impact in comparison with people who come at the start with a very good mental health. And I'm not just referring to mental health, but also neurophysiological stages. Also, we know that youngsters up until the age of 25 really have difficulty to be proactive, to make sure that they can create their own perspectives, future perspectives, and already have like a higher vulnerability of loss of perceived control, for instance. And so we created a narrative where we expected the honeymoon phase to be seen, and during the first lockdown, and then afterwards exhaustion would become apparent. So people would become much more irritable, much more responsive to polarizing voices, after which people would have a first adaptation, but it was just a minor adaptation because we expected people to then break down, because it's the second time that you are confronted with restrictions, with the need to reinvent yourself yet another time, that actually the psychological implications appear to be much more devastating than before. And afterwards, also a possibility, a window of opportunity to shift towards cultural adaptations, referring to the possibility to increase social cohesion, and that would be best done in this phase. And then afterwards, moving out of the pandemic, also expect some major shifts and peaks, because people need to reinvent themselves. And based on what I said at the beginning of the pandemic, it also accounts here, of course, not everybody finds it easy to reinvent themselves, and thus also explaining to some extent why people even today find it very difficult to uphold mental well-being. Also, the loss of carelessness is something that was created through the disruption of the pandemic, but it's not something that is actually easily redefined by people. And looking at the current crises that really came immediately after lifting the restrictions, it is very clear that a lot of people will still struggle for some time. So that was the narrative, actually one of the first things that we provided to policymakers, to offer them and to use that as a framework to kind of like explain to people what was going on and what could be expected. The narrative and the framework also where we could actually interpret all the data that was provided step by step. Another thing that we did was using all the data that we could look into, but also use existing literature to identify risk of vulnerability for risk factors for developing long-term poor well-being, but also protective factors, and thus explaining to policymakers where to target the scarce resources towards, rather than just going the elderly, the youngsters, and to make sure that those resources go where they are needed. And up until now, this list is actually fairly validated by new information that is now appearing through publications. Also, even of major importance today is actually financial insecurity appears to be one of the major predictors for mental distress. And as we are now in an energy crisis, it is apparent that people also suffer from financial insecurity, and that could have a long-term impact on mental well-being in people. Now, the way moving forward, using all the insights, today we still don't have a good alignment between the needs of the people and the availability and or accessibility of mental health and mental health care. There is an increase of unmet needs that was seen throughout the pandemic that is still not addressed today. with a clear necessity to be able to have some triage guidelines, good definitions, but also real-time referral systems that are efficient and just one click away, that are easy for people to use. Also, one thing that I want to point out is, up until now, all the research that I've seen is research on what we call the weird people, the Western, educated, industrialized, rich and democratic individuals. And all of that data is transferred and translated to people who are non-weird. And that's not the way forward. Actually, we do not know a lot about the people who are non-weird and in our target group. So also there is still a major gap to be breached. Also the impact on poverty, and I'm just sharing some of the data that I've been looking into. Again, poverty, but also financial insecurity. Remember that I said it's a major predictive factor for distress. Also, the impact on learning, as we see it in a post-pandemic, needs to be managed, as learning could be one of the leverages for people to uplift their distress and to know where to look for if they needed help. So in summary, I think basically what we've learned is that humans indeed are resilient. We predicted from the beginning that most of us would end up in an okay spot, not necessarily majorly resilient, but okay. And I think we see that today, but that the burden of mental health is indeed not equally divided. People at risk and people who are vulnerable today, they have a huge burden, and just providing means of those target groups is not the way to move forward, as they should be addressed with more resources, more support, more monitoring and more care. Now, more questions than answers today due to the lack of data, but also the lack of high quality research. Of course, in a crisis, we need to use whatever is available, but also today we are still dealing with some lack of high quality research, but also the underfinances of mental health uphold. We also need much more participative research to go and ask people what they think and what they use as leverages to actually address the non-weird population. So with those last actionable insights, I give the floor back to you, Brecht.
Perfect. Thanks a lot, Elke, for this very inspiring talk, and for reminding us that monitoring is, of course, not sufficient. We also need to transform our insights into action. So thanks a lot for these very inspiring words. Given the current time, I suggest we hold the questions that we have in the chat for a moment and pass the floor to Isabel Moens for her concluding or summarizing remark after having listened to the different presentations. Ms. Isabel Moens is currently a mental health care advisor to the Federal Minister of Health, Frank van den Broeke. Previously, she worked as Director of Mental Health at Zorgnet Icuro, the network of Flemish hospitals, but also mental health care institutes and social profit elderly facilities. Isabel has degrees in economics, mental health organization, and global mental health. So Isabel, we would be very interested to hear your reflections on the presentation so far. Thank you.
Okay, thank you very much, Brecht, and thank you also for the opportunity here to close this very interesting conference. 1 hour is also very short, but thank you very much for all those highlighting the most important elements. So I would like to start by saying that during the pandemic, we have seen really our mental health, both at the best of times, but also at the worst of times. We saw an enormous flexibility of services using new technologies in order to keep services open, but also new collaborations with, for instance, high schools and universities were found. But we saw also services crying for more capacity through all levels of care. And they felt sometimes left behind because of the important impact of COVID in the somatic hospitals. So COVID made us really realize how much mental health is important and that we need each other, and how interdependent we are, and how solidarity is really the way out. So let me first thank everybody for all the support and energy they have invested in putting mental health on the agenda, but also everybody on the field who day in, day out took very care for people with mental health problems. But we have to look forward. And on the basis of the lessons we've learned from COVID, we really need to make our health systems more resilient for the future. And resilience is, I think, really the key word that we've heard often in this presentation. And I will shortly handle 3 topics who are in line with the conclusions also of the speakers of today. The first topic is about structural, and not only in COVID times, but structural investments in mental health and scaling up services. So we knew already before COVID that investing in mental health is necessary. And beside the investments of the community and the regions, this minister, Frank van den Broeke, decided really to invest each year more than 200 million euros in mental health. And I'm not going to talk about all the measures, but the most game changer here and also for the future is to reinforce mental health into primary care. And so it can become a very solid basic of our health system. And this is an investment of in total 152 million euros. So that is really a very important budget. But investing in the resilience of health system, and this is a second topic, also includes to critically look at how it functions. And that involves improving the flexibility of our mental health care professionals to reach out to people who are more affected by the crisis, like, for instance, children, but also people living alone, people who are financially fragile, or also what we saw our workforce in the care sector. So therefore, we need really to defragment our health system. We need to integrate public mental health into a more strengthened primary care. So we need more close cooperation between primary care and mental care, but we need also to look beyond these. Consider the collaboration with other sectors like schools, nursing homes, public social welfare center. So decentralize and integrate where we need to be very close to the citizens. And why do we have to do this? Well, the major challenge is really to detect mental problems much, much earlier so that we maximally avoid escalation of mental problems or making them more severe. And that is the core of the reform in mental health care in this legislation, to make psychological care much more accessible, not only by increasing the budget, but also to change the mind shift of the professionals and the way we organize our services. And everyone is a partner in this story, and we need to do that to ensure that by increasing available psychological care and making it accessible, we also can reach more people and give them the care they need much faster. And as a last topic, I would like to emphasize the need for more scientific evidence and better data collection, which was never so desperately needed to guide policies. And Sciensano, the GEMS, but also the Supreme Health Council presented today their reports on mental health. So I think together with the KCE and EBP, it's the Evidence-Based Practice Network, they are conducting studies, research, and formulate opinions in the field of mental health. And besides, in this context, these federal scientific institutions can strive to optimize really cooperation towards a really health research system, which is an essential part of the health system. And this in particularly by aligning research agendas between these institutions, because aligning these research agendas will also be part of a more formalized network that we will start up this autumn to cooperate even better. And finally, it's essential that our scientific institutions
I believe, Isabel, that we have some connection problems. Yeah. Okay, but now we hear you again. So I think we missed the last sentence. Sorry for this.
The last sentence. So it was the third topic you've heard about the evidence, scientific evidence. So the last sentence I want to say about this is what the data collection means. And we think also that it's not only about research, we have to also to have good data quality. And we have this, for this, the yet to be established Health Data Authority will contribute really to the knowledge and documentation on and the availability and quality of data, and also in the context of mental health. So these 3 topics, and I will conclude, are very important elements for a change towards a better mental health care. And even if you're only at the beginning of this reform, in the light of upcoming challenges, such as the impact of climate change, the demographic changes, energy crisis, but also in the light of the digital evolution, like Martin said, our mental health system will need to profoundly change over the next decade. So I thank you very much for your attention, and thank you also to all the speakers.
No, and thanks a lot to you, Isabel, for these very important words. Thank you. So given the agendas that we probably all have, I suggest we can conclude this webinar, but I still want to say that I'm very happy that we've been able to have this discussion across institutes, bridging research and policy. I think this has been a very important exchange. It's also very good to see that there is indeed a strong consensus on the importance of mental health as a priority, both for care and for population health. And I believe we all understand that mental health is not just an issue because of COVID, but it's an issue in general, and it will continue to be an issue even if COVID is no longer making the headlines in the newspapers. So I look forward to continuing the discussion with all of you today and in the future, and I wish you all a very pleasant afternoon and look forward to seeing you on one of our next occasions. Thank you all.
Thank you. Bye.